Wagner. I am a psychologist and a researcher, and I'm going to be sharing with you today what we call some updates from the field. So I'm going to be talking about two different studies, one that's completed and one that's going to start. So the one that was completed is one I talked about here last year with MDMA and something called Cognitive Behavioral Conjoint Therapy for PTSD, which is a couples therapy. And then the other one I'm going to be sharing about is called MDMA plus CPT, which is a cognitive processing therapy. So for those of you who are here this morning and heard Mark speak about some of the psychotherapy trials happening with MDMA and PTSD, these are slightly different. So these are a different type of therapy being used for PTSD alongside MDMA. So I'm going to share that with you. So as you'll see here on this first slide, there are three different institutions involved in this work, and by institutions, groups, if you will. The first is Ryerson University, and so they've been a supporter of this work, so that's another institution who's behind this. MAPS was the funder of CBCT plus MDMA, and I'm really excited to announce that it's MAPS and MAPS Canada who are the funders of CPT plus MDMA. And Remedy, which is the home, or going to be the home of CPT plus MDMA. I might need some help forwarding the slides. It looks like that's not happening. Sorry, slight technical glitch. All good?
You might just have to click here.
Okay. Yeah? Okay. All right, perfect. So to orient us to what we're going to be talking about. So first of all, we have understanding PTSD. And so I think this is really important to understand why we think MDMA might work to help with the treatment of PTSD, is to understand PTSD to begin with. Secondly, I'm going to talk to you about treatments for PTSD, and these are ones that exist out in the world without MDMA. And so that's another really important piece of this puzzle. And one thing I actually do want to highlight is that some of these treatments do work. So we heard a stat earlier that only 10% of people get better. In actuality, when you use a treatment that works for PTSD, it's up to 50 to 60% of people do get better. The issue is the vast majority of people do not get the treatments that work for PTSD, so that's an important distinction. So I'm going to talk a little bit about MDMA. I'm not going to go into the molecular stuff about it, but just a little bit. We're going to talk about MDMA as an adjunct to three different therapies, and these are the ones that are separate and different than what we're seeing as the large trials that are pushing MDMA forward as getting approval in terms of being a medication for PTSD, but I'll explain that. Then I'll share a little bit about CBCT plus MDMA and then CPT plus MDMA. Okay, so what is post-traumatic stress disorder? What is PTSD? So PTSD is a specific set of things that can happen after a traumatic event. Now, oftentimes people will say things to me like, I have trauma. And that always is a bit of a question mark for me, because I'm thinking, what does it mean to say I have trauma? And oftentimes people are saying, I've experienced trauma. And really, there's lots and lots of different things that can happen after you've experienced a trauma. PTSD is one of those things. So they don't go side by side. They don't go hand in hand. PTSD is the most common psychological disorder that would happen after a trauma. But to experience a trauma does not mean you have PTSD. And in fact, the most common reaction after a traumatic experience is resilience. I really want to highlight that. So if you do have PTSD, what's going on? So the first thing is you need to have experienced a traumatic stressor. That means something specific has happened, or a collection of things have happened that cause a traumatic reaction. And these are specific types of trauma stressors. And there's lots of experiences, I want to emphasize, that can feel traumatic for people. There are things that are extremely difficult, things that we go through in our lives that can feel traumatic. The things that cause PTSD specifically are their own group of traumatic stressors. So these are ones that activate what we call the fight, flight, freeze response. You have a huge activation of a network that's happening in your body and your mind. And they cause feelings of fear, helplessness, and horror at the time or after the event. And so these are often things that are like the experience of a sexual assault, the experience of having a physical or emotional interaction that is so shocking that you think your life is at risk or could be at risk, or you're at risk for physical injury. So, or it can be the repeated exposure to traumatic sequelae. So things that, what that really means is when you see traumatic things over and over and over again. I see a lot of folks who've had childhood experiences of trauma, so they're repeated over and over, or first responders who are seeing at the scene over and over again. And so those can compound and form into a traumatic event. So that's one, something has to happen. Second, then we have a group of symptoms called re-experiencing symptoms. So this means that you have the experience of the trauma again, and that can be in the form of reminders that come up. It can be in the form of nightmares. It can be in your dreams. It can be anything that's cued or uncued about the trauma. But what it does is it causes that fight, flight, freeze reaction to occur again, and you're taken back to that moment. And so what people often you'll hear things that talk about things like triggers. And so when people are feeling triggered, it's because they're brought back to an emotional state or a memory that feels like the traumatic experience. That's re-experiencing. The second symptom cluster is something we call avoidance. So avoidance, which makes a lot of sense and works at the time, you want to avoid the thing that has caused the trauma to you. Of course, that's natural. And at the time, that is the helpful thing to do, to avoid that thing. Over time, though, when we avoid the things that cause the triggers, what that does is it teaches our systems that those things are things that we need to be fearful of and things that we can't work with. And so it reinforces that system over and over. And so this is often why PTSD treatments are so hard, is because you need to face the avoidance that's going along things and go into the emotion, the experience of the things you don't want to think or talk about anymore. So avoidance can be of people, places, things, experiences, conversations, emotions. They can be of basically as many people as there are in the world. There are different things that we can avoid. And so there is not one specific thing that we can label, but there are commonalities that could happen within avoidance. The third symptom cluster is negative thoughts and feelings. And so those are negative experiences that people will have in terms of their mood state and their view about themselves, the world, and other people. And so those negative thoughts and emotions really infuse across the whole experience of that person's world and life. And then fourth is something we call changes in arousal and reactivity. This again is directly related to fight, flight, freeze. So you have this internal reaction, this very somatic reaction to things that are going on. So you might experience things like heart racing, nausea, sweating whenever you have a reminder. And so this is why, for example, when we think of things like MDMA or other types of treatments, oftentimes they're trying to access in these areas that are more somatic or working in different areas than necessarily just your thoughts and emotions. What I'm going to be talking about is the necessity really of combining these different ways of approaching it so that we get the most healing possible for folks. So this in a nutshell is PTSD. So we have different types of PTSD treatments that are currently available in the world. So what I have listed out here are not necessarily protocols, so you may know of certain names of treatments, but these are approaches to treatments. So one is called exposure therapy, and so this is one where you are exposed to either the traumatic event or memories of the event, and it happens again and again, and so you become inoculated to it, so it doesn't have that experience anymore. The second is a type of treatment called a cognitive treatment. And these treatments get at the meaning making behind the traumatic event and why it may make you feel stuck. And so these are working on your thoughts and emotions. Oftentimes, exposure and cognitive therapies can go together, but they're also sometimes separate. There's another type of treatment you may have heard of called EMDR, eye movement desensitization and reprocessing. What this treatment is in fact, it is a cognitive and an exposure treatment, adding in a piece with an eye movement. Okay, so it is actually an exposure and cognitive treatment. There's also somatic treatments that are available, including neurofeedback, and unfortunately Heather's talk is at the same time as right now, so we'll have to chat about that at the panel after. There's also things called symptom management. So symptom management is when you're actually not treating the root cause of the trauma, you're treating the symptoms that come up. So for example, seeking safety is a very popular one that you may have heard of, and this combines substance use and PTSD and combine those together and creating a sense of safety. And that's an excellent thing to do if you're working on symptoms, but it doesn't actually treat the PTSD, it doesn't make it go away. And then there's also complementary treatments, which again work with some of the symptoms around it, but don't necessarily completely get at the root cause of the trauma. Things like art therapy and yoga can be very useful in addition to other things. So these are all different kind of modalities, we'd say, of treatment. And they can be delivered in different ways. They can be delivered individually, as couples, or in groups. Don't worry, I am going to get to MDMA in a minute, but just you need some background. Otherwise, it's not going to make any sense. Alrighty. Okay, so right now, in the evidence, the treatments with the most evidence so far, and I really put that in emphasis, because so far means that there's been large-scale clinical studies done on these treatments, which demonstrate their efficacy, their safety, and their feasibility. Those are very important words to understand, because those elements mean that they are safe to apply with people. They are not going to cause harm. So the two that have the most evidence are prolonged exposure, which is a type of exposure treatment. And if you were here earlier when Mark was talking about how sometimes people drop out of treatment, people do tend to drop out of prolonged exposure, and this is because it doesn't feel very good. But at the same time, most psychotherapy does not feel very good because you have to go in to go out, right? Like you have to dive deeper to come through the other side and feel the emotions. It doesn't mean it's harmful or noxious, though. It means that if people do prolonged exposure, they do often get better. And so the rates are 50 to 60% that would get better, but the challenge is when people don't want to do it. So there's prolonged exposure. And then the other one is something called Cognitive Processing Therapy, CPT. And that's an individual treatment that addresses your thoughts and meaning making about a traumatic experience. So these two have the most evidence out there right now in the world. And that also means they're the most widely disseminated. That means that they are being applied in hospitals and different clinics. People are being trained in these different treatments. And that's really important because if we're thinking about making psychedelics mainstream medicine, then we need to have people on board who are already providing treatments for these different things that we are potentially addressing. And so getting at that from a way of, oh, hey, I know that treatment. I wonder if we add something to it, could we make it even better? Could we make it even more effective for healing? So I'm going to plant that seed. So what do we need to work on? We've got some treatments that, work for some people, some of the time. They don't work for everyone. 50 to 60% of people getting better, hey, that's good, but you've still got 40 to 50% of people who are not getting well. We want to create options and choice. So a big part of dropout is because people don't like the options in front of them. If they have option and choice, they're more likely to choose a treatment that may work. And a huge predictor of people getting better is when they actually are invested in the treatment that they're doing. Right? It's a huge factor. As much as alliance with your therapist is a big factor, investment in the treatment is a massive piece of it. So, for example, in the MDMA studies that have come before, you see 0% dropout rate because the level of investment is so high in that treatment. We also need to work on for whom, why, when does something work? That's important. We don't know the answers to these things. In actuality, the treatment of PTSD has only existed for 30 years. So basically, when I was a toddler, the very first time a PTSD treatment that had any efficacy was introduced into treatment. So prior to that point in time, the treatment for PTSD was what we call palliative. That means we never thought people were going to get better from it. So that change has only existed in 30 years. We actually are starting to develop treatments where people no longer have a diagnosis of PTSD. But we have all these questions about who, why, where, when, how. And can healing be even more profound? So can people have even fewer symptoms when they finish treatment? Can they have healing in other domains and not just in PTSD at the same time? And can they also potentially heal around them, for other people, for their systems, for their families as well, which is so important. PTSD does not exist alone. It does not exist in a vacuum. It exists within communities, families, and that's so important because those families and communities keep people stuck and they can help them heal. So the use of MDMA in PTSD treatment. So MDMA is 3,4-methylene dioxymethamphetamine, for folks who don't know the full name there. It is what has been the active ingredient in ecstasy, but when we use it in clinical trials, we use the substrate, we are only using this compound. It's a monoamine releaser and has largest effects on serotonin, norepinephrine, and dopamine. What does that mean? What it means is when someone takes MDMA, their prefrontal cortex, so the part of their brain that is most highly associated with decision-making, emotional memory, things that their day-to-day experiences, comes online. And then what gets quieter is the amygdala. So the amygdala is the area of the brain that's really associated with that fight, flight, freeze reflex. And so that, if you have a brain scan, and actually Robin Carhare-Harris's team at Imperial College, take a brain scan of that, and then if you take a brain scan, if you show someone with PTSD, it's the reverse. So in PTSD, your amygdala is online and your prefrontal cortex is quiet. So if you could have designed a molecule that could work best for the treatment of PTSD, it's pretty much MDMA. It pretty much maps onto it. So, well, let's use it for the treatment of PTSD. So we combined MDMA with non-directive supportive psychotherapy for PTSD. So anything you've seen published up until now, Mithofer's work, Peter Owen's work, all of that has been with the type of treatment that is non-directive and supportive. It's had very good results so far. And part of the big question was like, will it expand out of the very capable hands of the Mithofers and Owen's team? I also really want to have a huge shout out to Annie Mithofer. Michael Mithofer gets talked about all of the time in this work. I love Michael, he's a great mentor, and Annie Mithofer is as much a part of this work as Michael, and I want to say a huge shout out to the women in psychedelics who are doing this work. We need more of you. Thank you. And shout out to the organizers who tried to have equity in terms of how the presenters up here, so sweet. All right, so that work has been phenomenal, and what it's done is it's created the ability for MDMA to be designated as a breakthrough therapy for PTSD. So that means we now have easier time getting things approved by the FDA, the DEA, and Health Canada, which is very exciting in terms of being able to make this work go forward. So in all the studies that have happened previously have all been on this route to legalization of MDMA for the treatment of PTSD. So all these studies have been designed as proof of concept and drug development studies. So that have that emphasis on it. So they're not playing with the psychotherapy, they're playing with the drug, and they're adding a psychotherapy onto it. And that's a distinction. So what this study is, and the work that we're now pushing forward, is how do you actually improve or work with the actual psychotherapy that goes alongside of it? Because there's a whole host of options, because we've seen all those different treatments that can work for PTSD. Can we make this stronger, better, more disseminable to other areas, have more clinicians be able to do this? So why would we do it? We want to test the concept. It's a empirical question. We need data. Let's see if it works. Even better, can we have different gains? Can we use this in health systems that currently exist? Because right now, the way that we do MDMA-assisted psychotherapy for PTSD is extremely time-intensive and labor-intensive. It takes 2 therapists to be involved in all the stages. And in a lot of healthcare settings, that's just not going to fly. So we can do it in research. We can show its evidence. And then how do we maybe make this something that we can actually use in different settings? And also, we want to address some concerns with current psychedelic and empathogen-assisted psychotherapy. I'm adding empathogen there because MDMA is an empathogen, not a pure psychedelic. So, and some of the concerns include, for example, we have a model of psychedelic and empathogen-assisted psychotherapy that was developed in the 50s and 60s. And we are in a different time and place than that right now. And in particularly, all of the previous protocols have required male, female, therapist dyads. And that is just not the reality of what necessarily we need or the constructs that we work with. Where are the folks who are non-gender binary folk? Where are trans folk? Where is the fact that, everyone embodies these different masculine and feminine characteristics? So the idea that we have to have these two archetypes present, it doesn't necessarily fit all the time. So, for example, we address that variable when we're doing it. So we don't require there to be male-female therapists. All right, so what this means is trying to look at different types of treatment for PTSD. There have been 3 pilot trials that have been funded and supported by MAPS and MAPS Canada. So there is one with prolonged exposure. You're going to see a theme here. It's going to be all the ones that are the most highly disseminated. So one is prolonged exposure, and so that study hasn't started yet. It's going to be at Emory University. Dr. Barbara Rothbaum and her team are going to be doing that study. They're already doing some precursor work on that. We have this study that we just finished, which I'm going to show you some results for, on cognitive behavioral conjoint therapy for PTSD. And so this was my team with Candace Monson and Michael and Annie Mithofer, and we ran the study in Charleston, South Carolina. And then the upcoming study, which is cognitive processing therapy for PTSD and MDMA, which we'll be leading here in Toronto. So CBCT for PTSD, in a nutshell, is a treatment that is dyadic, meaning 2 people take part in it. Usually it's romantic couples, but it could be any close couple. So it could be other family members, other friends. And it's a 15-session treatment that we do. And so I have to say, this is a treatment I do all the time in my clinical practice, and people get better with it. And so you don't need MDMA with it, but we wanted to test to see what would happen if we put MDMA with it. So phase 1 of the treatment involves psychoeducation, so teaching about PTSD, and safety building. Very, very important when you're doing any type of work, but especially couples work, so that it feels safe to disclose information about traumatic experiences, and that you're able to work with aggression and you're able to work with arguments in a way that is productive and useful for everyone. Phase 2 works on relationship enhancement and reducing avoidance. So this, you're doing behavioral things. You're actually programming in, we're going to approach the things that we avoid. And this can look anything like we avoid going to crowded places because he's just going to get too activated, to we don't talk about things that are challenging for us because we don't know what to do when our emotions get too high. So those things we work with and program in. And then phase 3 is you're challenging thoughts together. So you're challenging thoughts that are related to the trauma and related to the relationship together. And so you've got multiple sets of eyes working together to address those things. In a very quick nutshell, you can do a 2-day training on CBCT, but you got the 2-minute version of it. All right, so when we did this, CBCT plus MDMA, the idea was to create a safe and mutually understood experience to be able to enter the MDMA sessions with. And that's, I think, a real benefit of using a therapy with a protocol around it, is that you have a shared understanding for the couple of what they're going to be doing and how to work through things that are hard, how to have conversations, how to say, hey, that doesn't feel very good, or I need to share something with you. So it gives them skills and tools that are developed and then applied throughout the rest of treatment. We also allow for whatever experiences come up in the MDMA sessions. And so what that means, I'm going to show you the sequence of things that we do with that, but meaning that in those sessions with MDMA, we're not directing it. So it is in a session, in a way, taking the best of the non-directive supportive approach and applying it into this approach. We also integrate through the use of the skills and tools that they learned ahead of the MDMA session afterwards. And so they're able to work through the different themes that are coming up with those skills and tools. And it really creates a scaffold to tether the experience to. So whenever we think about integrating psychedelic and empathogen-related experiences, we often think about the scaffolding experience, the idea of you can never hold on to the whole experience. You can never remember every single part, nor would we want to. The idea is more that you've been to that place, you've had that experience, you now have a scaffold, you have a map of where you were. How do you take that going forward? How do you use that? And so using a treatment to support that can hold that and create that scaffold for you is very useful in terms of making sense of the experiences. So what does it look like? So CBCT for MDMA, with MDMA looks like this. So the stars are the different times that we assess people. So that means we're testing to see what their symptoms look like, how they're doing. So we have it at baseline, halfway through treatment, 1 month after treatment, which is the post-treatment, 3 months and 6 months. And so we start with 2 prep visits. So that's a conversation, lots of questions about what is this, how's it gonna feel, what's the safety around it. That's the preps. Then we do in-person CBCT, and we condense it down. So we're doing these intensive weekends together. And so the first in-person CBCT, you've got essentially what would be 3 sessions of like weekly psychotherapy smushed into 1 day. And then the next day, we would do 2 more sessions smushed into the morning, and then we give the dose of MDMA. And then, so important here for CBCT, both members of the dyad get MDMA. So they're both taking it together. Also just want to highlight that that is the first time the FDA has approved someone without a diagnosis taking MDMA. So we've got some nice safety data coming out there. And so then they have just been primed, right? They've just been doing some work together. They take MDMA, and they have a full day experience, and we support them in that. The next morning, we integrate. So basically, we talk about the experience, and then we set up some homework going forward based on the work they've done prior to the session. Then over the next 3 weeks, we did 4 sessions of CBCT. In this case, we did it over telehealth. That was purely pragmatic because Candace and I live in Toronto, Annie and Michael live in Charleston. We flew back and forth. We did over telehealth. Then they come back. They do in-person CBCT again, another MDMA session, integration, and then finish out the CBCT protocol. So, data. This is going to look like a lot of numbers. It's going to make sense really quickly. So this is the self-report data. So that means the data from the person with PTSD and their partner. So what this means is the first CBCT visit, so that's the first time we sat down to do therapy together. End of therapy, that's the last day. And then that 6-month follow-up, so 6 months later. The PCL is a rating, a trauma rating, and it rates the symptoms of how severe they are. And so you can go on this scale from 0 to 80. 80 is the highest you can have. And your relationship satisfaction is from 0 to 6. Now 3 on relationship satisfaction means happy. 6, okay, my hair is in the way of the mic, so that's a bit of a problem. Okay, so 0 to 6 is the relationship satisfaction. Now, if anyone ever says they're 6, which means their relationship satisfaction is perfect, I have a big question about that, because I think that that's maybe not so accurate, and we might be dealing with something else there. So what I want you to take a look at, I'm going to put little boxes around these. So the PTSD positive is the person with PTSD, partner is their partner. Okay. So this couple started off 44 and 29. So that's 44 is like pretty severe PTSD on this scale. And you'll notice that their scores came down and got closer together. That means they have a shared understanding, and a clinically significant change on this measure is 10 points. So we've got 20 points. Yes?
What's the PCL of the partner? Whom is referred to?
Thanks for that. So the question is, who does the PCL of the partner refer to? They're rating their partner's symptoms. So only one person has PTSD in this. Okay. So this person, they had good results, and they were maintained at follow-up. So they're like, that's a strong drop in their symptoms. Their relationship satisfaction went from not very satisfied to satisfied and improving over time. Second couple, very high PTSD symptoms. And you'll notice this discrepancy between person with PTSD and partner. That's really common at the beginning of treatment because they're not talking about what's going on. End of therapy, 11 and 5. So anything below, anything actually probably below a 20 is not considered PTSD. Actually, it's higher than that. 23 is the kind of the cutoff for PTSD. And maintained at 6 months, and the relationship satisfaction is quite stable over time. Couple number 3. So this couple I wanted to highlight is the person with PTSD was very, very dissociative, which means that they had a lot of difficulty staying in the moment, And what we know anecdotally is this person had a huge reduction in the dissociation, but their PTSD was still strong. So that leaves questions for me around perhaps they needed another session, another MDMA session. Perhaps they needed something a little bit like a slightly longer protocol. So that was one thing, but their scores came closer together and kind of maintained at that. The partner's rating certainly changed, and their relationship satisfaction improved. Now you'll see a theme for the next three couples of massive drops and improved relationship satisfaction, massive drops, improved relationship satisfaction, and massive drops and improved relationship satisfaction. So yeah, so the theme's pretty clear in terms of that they're doing well. And some of the quotes that went alongside people's experiences, and I just pulled this out from different sessions that we had together. I asked, a question in one of the sessions, or actually asked this in an MDMA session, of saying, what do you think it would feel like if PTSD wasn't here right now? And the response was, well, I know what it would feel like because PTSD isn't here right now, which I thought was pretty amazing. And another participant said, I feel like the weight has lifted. We started unraveling the strings that had been in knots one at a time, and then the whole knot came undone. I feel different, and it feels great. I never imagined there could be this much healing. And thank you for giving me my life back and helping us with our marriage. I just have this overall feeling of inner peace, and I didn't believe there could be this much healing. So those quotes, even in the hardest days of the study, kept me going, and I was pretty excited to hear those. So that was that study. We've wrapped that study in the spring. We're in the process of writing up the results. We're actually going to be presenting the full results with the clinician-rated measures as well at the International Society for Traumatic Stress Studies. So that's another exciting thing is the results. So when I'm here, it's fun because I feel like I'm preaching to the choir. Like, you're all interested in this topic. And then I go to academic conferences of psychology and trauma, and there's a lot more, you have a lot more hurdles to get over, and a lot more, the strength of the data and the evidence you need to provide needs to be so accurate and specific and strong, because there's an innate barrier to wanting to accept what's going on with that. And so I'm going to be presenting the full results of the study in a spoken presentation for this international group of trauma researchers in November, which is an exciting platform to have been given. So that's that study. We've wrapped. Exciting. We're going to be publishing a case study on it in the Journal of Psychoactive Drugs in a special edition that's coming out, so watch for that. And then now, what do? So now we are doing another study. So we're doing the third of that trifecta of different treatments, is cognitive processing therapy plus MDMA. So we're going to do the same approach as CBCT plus MDMA, including 2 MDMA sessions. And CPT is a 12-session protocol, so even shorter. So we're going to condense it down even further. And it's focusing on making meaning of the traumatic experience. So this is almost a purely cognitive experience. So cognitive and plus the somatic piece around the MDMA. It's individual delivery, so that's one person. And our likely design is going to look like this. 4 sessions of CPT smushed together, 1 MDMA. 4 sessions of CPT spread out over 3 weeks, MDMA, 4 more sessions of CPT. So we'll be able to do that whole protocol, which would normally take about 10 to 12 weeks. We'll probably do it in about 6 to 7, so we'll go even faster. And also to think about some differences we're going to do with CPT plus MDMA is we are likely, this isn't confirmed yet, but we are likely going to only have one therapist delivering the therapy. And then in the MDMA sessions, we're going to have a support therapist, meaning that, quite frankly, sitting with someone for 8 hours, you do need to take a break occasionally. You need to stretch, have a snack, go to the washroom. So we're going to have someone else there who's trained, who's able to be with the other person should anything arise when the other person's out of the room. But there will only be one main therapist. And this is a big change in terms of what we've done in a lot of other treatments. Also, this individually delivered protocol is closer in terms of an individual protocol to the non-directive supportive model. So we'll see what that looks like. It's an empirical question. We don't know, maybe non-directive supportive is the better way to go, but we should test it out and take a look. Also, this is going to be an investigator-sponsored study, which means that MAPS is the funder, but they are not running the study. We are running the study, which also is different, meaning that we're going to be starting to build capacity beyond the larger funding bodies to be able to run these studies independently and through our academic institutions and developing with their support. So that's actually developing our capacity here, and that's a huge, I don't know, not risk, vote of confidence, I guess, from MAPS and MAPS Canada, asking, allowing us to build this work and create a center for it here. So I think I've got time for questions. Okay, fabulous. So I'm going to move it there. This is me. And thank you so much for your attention. I'm so happy to take questions. Yes.
I worked for many years, 35 years, with people with PTSD.
Mm-hmm. Excuse me.
Many of them were not able to have a relationship with anybody. They're totally isolated. Would that mean they would be excluded from your study? I don't understand what that has to do with.
Right, so the question is, this woman has worked for many years with folks with PTSD, often who are very isolated and don't have other people in their lives. Right. Yes, and so for the CBCT one, they would participate with someone, right? It could be a friend, it could be any family member, anybody. But that's also why we have the option and why we're testing CPT, where you do it alone. So that's when I talk about having option and choice. So when when people do have people in their lives, oftentimes PTSD plays such a huge role in that system of the people in their lives that it's useful to have those people involved in the treatment. But also we need individual treatments for when people don't have people in their lives or choose to do it on their own. Thanks. Yeah.
Do you have a control study for the control group? Sorry.
Yeah, great question. So the question is, do we have a control study? Not yet. So what these are, they're pilot studies as proof of concept. And so meaning that we're collecting data to even see if it would be worth it to take it to a randomized control trial. And so what we're debating, because the CBCT results look good, initially we were going to do 10 cases. We stopped at 6 because the results were so strong. And what that means is then moving to the CPT pilot, which will hopefully then quickly be able to move us on to a randomized control trial of the CBCT plus MDMA. And in that case, the big question will be, what is the control group, right? Because, yeah, the question is, it is very hard to find a good control drug or placebo for MDMA. There's been different placebos, drugs used in different studies, including low-dose MDMA, which just produces anxiety in folks with PTSD. So please don't use low-dose MDMA for people with PTSD. It doesn't look so good. And so what we actually think it may be is, for us, because we're actually testing the psychotherapy, is it may just be CBCT versus CBCT with MDMA. Right? So we might compare those two things together, and we'd condense the treatment down into the same format. You get like weekend format of it, but we're still working through that because we do think we'd probably have to give a pill of something so people aren't going to know. Yeah, thanks. Yes.
So I'm not a clinician, so I don't know what the actual context of this is, but so you were talking earlier about correct me if I'm wrong, about in PTSD, in broad strokes, you get overactive amygdala, underactive prefrontal cortex, and in MDMA you get the opposite pattern. So I've read a few studies like in the last while about sort of delineating like a dissociative subtype of PTSD, in which you actually, when a person is triggered, then they have actually the opposite pattern, overactive PTSD, underactive, and just suppression of like sort of patterns automatically. So I was wondering how that sort of like fits into this, and I also noticed with the one couple where the person had sort of a lot of dissociative symptoms, but they had more of a problem sort of getting better. So I'm just wondering what you thought of the path forward was.
Totally. Thanks for that question, because it's a really important one, and one that I'm going to repeat the question for folks who didn't hear it. So it's around the dissociative symptoms of PTSD, and there is now discussion of a dissociative subtype. It's more in the ICD, the European version, than the DSM at the moment. So the dissociative subtype, and it's true, is that dissociative symptoms do have a different brain activation than PTSD when the dissociation is not activated. And colloquially, what I was sharing was that the client that had the highest dissociation had the least strong result in terms of our study. And actually what they're doing for phase 3 is they're ruling out folks with dissociative subtype. And ruling out only meaning that that's for that study particularly because of trying to get approval of the drug. So this is really speculation, this is not on data, please take it at that, is that I think we would need to potentially work with the dissociation a little bit first and then get after the PTSD. What I do clinically when I'm not using MDMA with folks is we do work with the dissociation and we integrate it a lot at the beginning, and it's, it does work. It sometimes takes a little bit longer to work with and slightly different technique to work with it. But there might be something a little bit before, maybe a little bit longer, because this person, their dissociation went down, but their PTSD was still active, which says to me that maybe we just need a little bit longer in the treatment or another MDMA session. So it's still a question that's out there that we need to do some work on. Thanks.
Last
Yeah.
question.
Okay, sorry. Last question, and I'm around later, so yeah.
Me?
Yep.
I'm wondering about the couples therapy. I know generally the vehicle for therapeutic psychedelics is kind of blindfold headphones and go into yourself. With the couples therapy, is it two people with blindfolds, or are you doing groovy things, or what is
Yeah.
it?
Great. So the question is, what does it look like when you're doing couples therapy, when typically the model for doing psychedelic and empathogen-assisted psychotherapies is blindfold and headphones on, very internal experience. So we do both. So we do actually encourage a lot of time, what we say time inside. So people have eye shades, we use the playlists, we do the headphones. Annie Mithover's the best DJ ever for those sessions. So we do that. We encourage lots of time inside. And then what we do is we ask the person, when someone wants to speak or share something, they flip up their eye shades and they call over the therapist, and we chat for a second, and then we check in with the partner to see are they ready, or are they in a place where they want to or have a conversation, because they may be in the middle of a process that we want to let them finish out. And what we noticed early on, especially with the first cases when we weren't such great conductors between the two, that as soon as the person with PTSD had something to say, their partner was like, what? They really wanted to know. They really were there and present. And so we had to orchestrate it a bit more, more time inside, so that everyone could really get their fulsome experience. Yeah, so it was a bit of a dance between the two. Yeah, thanks. Okay, thank you so much for your attention, and we'll see you at the panel.